Hello, I am Dr. Brijesh Saran. I am a psychiatrist and working as an assistant professor in Santosh Medical College. And today I welcome you for the topic. It is about the serious mental illness named schizophrenia. And in layman, I will tell you it is a very common mental disorder. What happens in that person is unable to differentiate what is real and what is unreal, and he also have a difficulty in thinking clearly because he is lost in internal stimulations like hallucinations, and he also have difficulty in managing his emotions, and ultimately he have difficulty in maintaining any relationship with others, and which leads to difficulty in holding a job for long duration, or he is unable to function normally. So it's a very simple definition. So I will start with the historical background, how this concept of schizophrenia came to be known. That in the year 1896, it was the Emil Kraepelin who first coined the term dementia precox, which means a person having a paranoia or hallucinations in the form of delusions and hallucinations, and patients are usually young onset, very early age, adolescent onset illness was there, and it was given the name of dementia precox to differentiate it from the manic depressive illness. So at that time in the 1896, this term was coined. And what happens that usually it is symptoms similar to dementia was accepted at that time, and with the early onset, which also include delusion, hallucination, and the changes in the facial expression or disturbances of affect and motor disturbance in the form of catatonia. Then in the year 1911, the Eugen Bleuler, he coined the term schizophrenia, which we now use, which means mental splitting. Literally it means mental splitting, but there is no splitting of mind is not there. So it is used to define a group of schizophrenia which have fundamental symptoms like 4 A's, which is commonly known as Eugen Bleuler's 4 A's. Number one is ambivalence, where the person is unable to decide for or against for any thought or any activity. The second A is the autism, in which person withdraws to self. Third is the affect disturbances, in which person shows inappropriate affect or facial expression or emotion expression. And the fourth A is the associative disturbances, in which person have thought disorder. They have in the form of loosening of association, and they are manifested as speech disturbances when we talk to the patient. So these four fundamental symptoms were important according to Eugen Bleuler in the year 1911, and he coined this term schizophrenia. He also suggested certain accessory symptoms like delusion, hallucination, and negativisms. Next, we have Kurt Schneider in the year 1959. He gave the Schneider's first rank symptoms. Usually, we call it as in short as SFRS. So these SFRS are many numbers, and they are still used in our current diagnostic symptom classification. So these SFRS are that time considered diagnostic for diagnosis of schizophrenia. They also have second rank symptoms like hallucination and perplexity. So importance was given to the SFRS by the Schneiders in the year 1959. So SFRS contain various symptoms of diagnosis of schizophrenia, like number one is the audible thoughts, which include voices heard arguing about the patient, voices commenting on the patient actions or behavior. Thought withdrawal might be there, thought insurgent, broadcasting, where the thoughts are supposed to be appeared in the mass media like TV, television, FM, newspaper, or other print media. They all have information about the patient thoughts. So we call it thought broadcasting, which is one of the SFRS symptom. Then they have made phenomenon, in which person feel that their feelings, impulses, and all voluntary act are being controlled or made by some external forces. Then another symptom of SFRS is the somatic passivity, in which bodily sensations are the most common symptoms, and they are being controlled by some external forces. Then they have delusional perception, in which normal perception has a private meaning which is illogical according to the patient. So these are the SFRS which were mentioned by Kurt Schneider in 1959, and these are the very important symptoms. Now currently we use one more way of classifying the schizophrenic symptoms, or simply the psychotic symptoms which are found in schizophrenia. Now we call it as a positive symptoms and negative symptoms. Positive symptoms are five in number: delusions, hallucinations, bizarre or disorganized behavior, disorganized speech, usually the positive formal thought disorders, or catatonic motor behavior. Negative symptoms are also five or six in numbers, like inappropriate affect, alogia, affective flattening or blunting, evolution apathy, anhedonia or asociality, or there might be a attention impairment. So all these five and six positive negative symptoms are commonly explored during the diagnosis of schizophrenia, and they are helpful in making diagnosis of schizophrenia. So clinically it is a disorder of thought, and it is manifested in the patient's speech. Also they have a perception disorders in the form of hallucination, or maybe most commonly auditory, visual are the next one. Then disorders of affect, in which patient have inappropriate facial expressions. Then disorder of motor behavior is there, not common but not very uncommon. It is also seen, like catatonia and negative symptoms which I have just enumerated. So we talk about the latest diagnostic classification, which we call it as ICD-10, and they have compiled previous symptoms according to the latest research guidelines for easy diagnosis throughout the world. So it is a WHO which comes out with ICD-10 classification for psychiatric disorders. For schizophrenia, they say that if there are four symptoms are there, four set of symptoms, and any one set is present for 1 month duration, then we call it as a schizophrenia. So what are those four symptoms are? Thought echo, insurgent, withdrawal, or broadcasting. If any one of them is present for at least more than 1 month, we call it schizophrenia diagnosis. Other three symptoms are the delusion of control. It is very important, most commonly found only in schizophrenic patients. Delusion of influence, delusion of passivity, which may be focused on the body part or limb movement, or patient may have a passivity for his thought, actions, or sensation. If for sensation, we call it as delusional perception. So it is the second symptom. If it passes for more than 1 month, we call it a schizophrenia diagnosis. And the third symptom is the hallucinatory voices. They present in a three variety, like a running commentary on patient behavior, or second, they may be discussing him as a third person, or third modality may be the voices coming out of some body parts. So all these are diagnostic of schizophrenia on the hallucinatory voices spectrum. Then the fourth one is the persistent delusion, which are culturally inappropriate, impossible, such as religious, political, identity, superpowers, and abilities. Extra abilities are the content of these persistent delusions, which may persist for more than 1 month. So these, out of these four symptoms, if they persist, any one persists for more than 1 month, we make the simple diagnosis of schizophrenia. Then we have next four more symptoms. If combination of two are present, then again we make the diagnosis of schizophrenia. So number one, out of that fifth one is number one here. So we call it as a persistent hallucinations, break or interpolation in the train of thought, presenting as a incoherence or irrelevant speech or neologism. Or next one is the catatonic behavior. It could be stupor or excitement associated with posturing or flexibility, negativism, mutism, and obviously the stupor. So all these are the catatonic behavior. They manifest as motor behavior changes in schizophrenic patients. And then fourth one is the negative symptoms, which include alogia, affective flattening or blunting, evolution apathy, anhedonia, asociality, attention impairment. So out of these four, if any two combination of symptoms are present, like persistent delusions, thought blocking, catatonic behavior, or negative symptoms, then we make the diagnosis of schizophrenia according to the ICD-10. So this is the latest guidelines for making the diagnosis of schizophrenia. There is one more last component is there. Sometimes these symptoms, out of these 8 symptoms, are not present. only we find that there is a significant and consistent change in the overall quality of some aspect of behavior, which manifests as loss of interest, aimlessness, idleness, or a self-absorbed attitude or social withdrawal lasting at least for 1 year period. Then we also make the diagnosis of schizophrenia. So these, when we find these symptoms, we make the diagnosis, and then we categorize into clinical subtypes like paranoid schizophrenia, which have predominant delusional symptoms are predominant, positive symptoms are there in the form of hallucination and delusions. Disorganized, they have also called hephrenic subtype. So in this disorganized, there is a disorganization of behavior is there, in which person tend to do abnormal behavior, like eating from the garbage bin, undressing in front of others, passing urine and defecating in front of others, or touching the feet of others. All these inappropriate behaviors or disorganized behavior, they come under hephrenic schizophrenia subtype. Third one is the catatonic schizophrenia, where there is akinesia is there, marked slowing, profound slowing of the body movement is seen, with other catatonic symptoms like waxy flexibility, negativism. Now the fourth subtype is the residual or latent schizophrenia, which have predominant negative symptoms may appear, and in the past 1 or 2 years back they have transient or fluctuating presence of hallucination or delusion might be there, which are not present currently. So only they have predominant negative symptoms are there. Then we have undifferentiated schizophrenia. Patient symptoms doesn't fit in paranoid, disorganized, or catatonic or residual category. Then we put them into undifferentiated when more than two subtypes are present together. Then the next one is the simple schizophrenia, which also have symptoms very difficult to diagnose, but there is a very slow gradual onset of negative symptoms are seen. Next category subtype is the post schizophrenia depression, which have a history of psychotic symptoms which subsided, followed by major and minor criteria of depressive symptoms are there, and patient also having death wishes or suicidal ideation. So after episode of psychosis, patient goes in depression, depressive phase, we call it as a post schizophrenic depression. Then other subtypes are also mentioned like schizophreniform, aneroid, Van Gogh, late paraphrenia, Fromm schizophrenia, type 1 and type 2 schizophrenia. So all these are the clinical subtypes which help to make the diagnosis. Now after making a diagnosis, we look for the differential diagnosis. Like there are multiple differential diagnoses. Number one is obviously the organic cause. Most common, we have to rule out the complex partial seizures, drug-induced psychosis like steroids, metabolic disturbances, then space-occupying lesions in the brain. They all are the common organic causes which look like a schizophrenic or psychotic patients. Second diagnostic category to rule out, differentiate, is the mood disorder, which include mania, depression, or mixed affective episode, or schizoaffective disorders, which have both psychotic and mood disorder at the same time. In mood disorders, which we include bipolar disorder, so at some time patient have manic episode history, or sometime they have a depressive episode history. Now the third category of differential diagnosis is the delusional disorder and ATPD. In delusional disorder, there is only delusions predominantly are seen, and which are of 4 or 5 different types like paranoid, jealousy, infidelity, somatic delusions. All these comes under the spectrum of delusional disorders. Then ATPD is the acute and transient psychotic disorder, also known as brief psychotic disorders. In ATPD, patient have polymorphic symptoms, which means they change with time duration, within hours or days or weeks they changes, and they resolve very quickly after treatment, and they present within 1 or 2 weeks of clinically symptoms are there. They look like a schizophrenic symptoms, and they have a good prognosis. So we call it as ATPD, or acute and transient psychotic disorder, and their onset is most of the time is preceded by a certain serious stressful life event. Then we have to look for the comorbid physical disorder and psychiatric disorder. Physical disorders like diabetes mellitus, which is most commonly seen in schizophrenic patients, and other psychiatric disorders like depression, anxiety, alcohol or drug misuse, or personality disorders. There are also comorbidly seen as psychiatric comorbidity. Now, so we have to see clinically during the making the diagnosis of schizophrenia. We discuss the type of symptoms, positive, negative, or IC10 symptom, then subtypes. So clinically, when we assess the patient, we look for certain thing. One is number one thing we should observe before making someone having declared as a psychosis. Number one thing we should know that there is a impaired reality testing, so in which means that person is not in contact with the reality and he is unable to differentiate between real and unreal situations. So whatever is going on inside the brain, inside the mind, and whatever is going in the surrounding, he is unable to differentiate. They look alike, similar to the patient, and there is no boundary, and they are unable to differentiate between the internal and external environment. So this entity is called as gross impairment in reality testing. Now there will be marked disturbance in the personality is there also, with impairment in social, interpersonal, occupational function decline is seen once the psychotic episode occurs. So this has to be observed, and there will be a disturbance in the judgment, which is almost impaired. So patient, whatever action he is doing, he is not knowing that its consequences will be good or bad. He has no judgment to decide them. Now they also have a loss of insight, which means whatever symptom they are going through for psychotic symptoms like delusion, hallucination, they think they are real, and they have no awareness that they are the psychological symptoms. So insight basically is absent. Then presence of positive symptom also support the diagnosis of psychosis like delusion and hallucination. So these points should be explored clinically while making the psychosis diagnosis for schizophrenia. Sometimes these psychotic symptoms are also present in other psychotic disorders, so we have to be very much careful whether patient have showing these psychotic symptoms, they are suffering from schizophrenia or suffering from manic depressive psychosis, which may include depression with psychotic features, or mania or hypomania with psychotic features. We have to be careful. And other psychotic disorder, third category of psychosis, we have a long differential diagnosis. We should also differentiate them. So to enumerate them, I will let you know. One is the other psychotic disorder. Number one is stereotypal disorder, in which person have a eccentric behavior and thinking, and affect abnormalities like schizophrenia are there. Then second one is the persistent delusional disorders will be there. Third one is the acute and transient psychotic disorder. Fourth is induced delusional disorder. Fifth is schizoaffective disorder, and other or unspecified psychotic disorder. So these are the three different type of psychosis which we must differentiate from schizophrenia, because they all have similar psychotic symptom as positive, negative symptom present in all these three different type of psychosis. So we talk about the treatment part now. It includes pharmacological treatment, and we have there is a lot of benefit for the patient once the symptoms are resolved, and it is done by giving antipsychotic medications are given. If we delay the treatment, then the responses are also delayed, or patient may become more worsening of the situation may occur, or there might be no response to the medication is also seen. So there should not be any delay. Even a brief delay may cause a abnormal behavior, or patient may involve himself in certain substance abuse, or they may develop severe stress, or they may prone to develop some other psychiatric disorders or medical illness. So immediately the moment we make the diagnosis of psychosis, patient should be started on antipsychotic to prevent the worsening of patient clinical condition. Now before most of the time we do not have time when patient have acute psychotic episode to assess them on lab test to rule out the medical disorder. But for diagnostic sake, for knowledge sake, we must know that there are certain lab tests are there, routine lab tests like CBC, electrolytes levels, fasting and glucose level should be known, and this hemoglobin A1C should be done, lipid profile, liver function test, renal function test, and thyroid function test should be ordered the moment we know the patient is suffering from psychosis. So most of the time in psychotic episode we don't have time, as I told you, so we have to start the medication in the initially, and these lab tests can follow in a 1 or 2 days. Some other conditions are there. Special situations comes when we have to go for special investigations, like pregnancy test and movement, because these medications can harm the fetus. Or we also get the HIV test done or syphilis test done in certain special population like IV drug users, to differentiate other diagnosis. They present also as a psychosis. Now we also have to be careful before giving medicine, that we have to be looking for the pre-existing tardive dyskinesia. Sometimes patients have prior exposure to the antipsychotics, and they may develop certain antipsychotic induced side effects, and one of them is the tardive dyskinesia, in which there is a rapid movements of body parts is there, and such patients should not be given antipsychotics at all. So antipsychotics are relatively very safe, and we can delay the lab test for next 1 or 2 days till the patient gets his abnormal behavior gets stabilized, except certain conditions. Now there are two types of antipsychotics are present at present. We classify them as two main groups. One is the FGA and second is the SGA. FGA means first generation antipsychotics, and second group is the second generation antipsychotics. So FGA are very high. They can be further divided into very potent, low potent, or mid potent. So low, mid, or high potency drugs, and they act on the D2 receptors, and they have a tendency to cause certain side effects like EPS or acute dystonia are the most common side effect with the high potency first generation antipsychotics. Now, but the low potency antipsychotics also have their other side effects. They're less likely to cause EPS, but they can cause postural hypotension, sedation, weight gain, or anticholinergic side effects. So we must be aware. So for the knowledge sake, I will tell you what are the antipsychotics, how they are classified. So if we look for the second generation antipsychotic, they also have side effects like metabolic syndrome. Person tend to have hyperlipidemia or diabetes mellitus, weight gain, obesity might be there. So these are the side, but EPS, tardive dyskinesia, they are not observed with these second generation antipsychotics, and they act on the D2 receptors also. They are partial agonist or partial agonist to the D2 serotonin 2A receptors. They are also seen. So drugs which are acting on the D2 agonist, which are partial agonist for the dopamine, are the aripiprazole, brexpiprazole, or cariprazine. These are the three drugs available as the antipsychotics which have partial D2 agonist action is also there. Then we have dopamine D2 serotonin 2A antagonist drug classification, which include acinapine, clozapine, iloperidol, lorazepam, and olanzapine, and paliperidone, quetiapine, risperidone, and ziprasidone. Then we have first generation antipsychotics, some drugs we should know, which directly acts on the dopamine as an antagonist, like clopramazine, fluphenazine, haloperidol, orphanazine. So these are the name of the antipsychotic drugs we must know. Now all antipsychotics are effective similarly, but some exceptions are also there, like clozapine is more effective than any other FG or first generation or second generation antipsychotics. So it is seen that certain second generation drugs are better than other antipsychotics besides clozapine, like amisulpiride, olanzapine, risperidone, through some meta-analysis studies. Now one of the Cutlass or Catty studies, they say that clozapine is very advantageous drug in the cases of refractory schizophrenia whose symptom does not resolve with FGA or SGA. Then we tend to give clozapine. It's a very good drug, but it also comes with side effects like severe agranulocytosis might happen. So these side effects of clozapine should be kept in mind. Now the route of administration should be known. Oral tablets, injections are also available, and which is very effective. Drugs are very effective, and a patient they do respond very well within 10 to 15 days. So I will close my session here, and thank you very much for joining the session. Thanks again.